How's it going, guys? We have a medium difficulty question for step 1 pathology as well as step 2 internal medicine. I will keep this clip consolidated. We could spend 24 minutes discussing every answer choice here. So before we get started, please subscribe to my channel. I really appreciate it. Give the video a like. Really appreciate it. Find me on Instagram at Mehlman_medical, MEHLMAN_medical. Links down below. Find me on Telegram. Recently created a Telegram group and channel. Links are down below. Now let's start the clip. 19-year-old woman. She has a 4-month history of joint pain over knees and hips. Violaceous rash is seen on her nose and cheeks. We're handing you the diagnosis of SLE. Okay, lupus, not hard. Okay. Hemoglobin 10 grams per deciliter. This is going to be anemia of chronic disease. Okay, so normal range is 12 to 17.5 in menstruating women, 13 to 17.5 in non-menstruating women and men. Obviously, young women menstruating can get iron deficiency anemia, but combined with autoimmune disease, it's anemia of chronic disease. ESR elevated at 25, should be under 20. Blood urea nitrogen elevated at 35, should be under 20. Creatinine elevated 1.7 milligrams per deciliter, should be 0.7 to 1.2. So this is lupus nephritis, usually diffuse proliferative glomerulonephritis and nephritic syndrome. So what else is most likely to be seen in this patient? Let's just walk through the answer choices. Choice A, antihistone antibodies, wrong fucking answer. This refers to drug-induced lupus. There's no mention of a medication here. Okay, so drug-induced lupus is not the same as just regular systemic lupus erythematosus. So in regular SLE, we've got anti-double-stranded DNA, we've got ribonuclear protein, anti-Smith antibodies, but antihistone antibodies, drug-induced lupus. So hydralazine, isoniazid, procainamide, penicillamine, minocycline. It's not that you have to memorize the specific drugs that cause drug-induced lupus. Don't worry. It's more a matter of like if they were to give you a patient who took procainamide for like as an was given procainamide as an antiarrhythmic, and then gets arthritis or mediastinitis, pleuritis, etc. You want to think of drug-induced lupus, okay, antihistone antibodies. Wrong fucking answer. Choice B, antimicrosomal antibodies, wrong answer. This refers to Hashimoto. Okay, so Hashimoto thyroiditis can be antimicrosomal. That's another name for antithyroperoxidase, as well as antibodies against thyroglobulin. Okay, so that's going to be hypothyroidism. Very, very high yield, a lot we can talk about, especially for 2CK level stuff. Okay, so myopathy, you can get dysthymia, depression, menstrual irregularities, transaminitis, high ALT, AST. Sounds weird, but you can get it with thyroid dysfunction. And the myopathy, by the way, increased creatine kinase, and you can get high cholesterol, bradycardia, peripheral edema, low sodium. Okay, wrong fucking answer. Choice C, anti-smooth muscle antibodies, wrong answer. This refers to autoimmune hepatitis, okay? Low yield diagnosis. This would in theory be generally a woman, 20s to 30s, who just has high ALT, AST, and you've ruled out other things, okay? Diagnosis of exclusion, all right? So essentially when you're contemplating differentials in a patient who's got hepatitis phenomenon, okay, and you've ruled out the viral infections, you've ruled out primary biliary cirrhosis, other causes of biliary obstruction, okay, choledocholithiasis, primary sclerosing cholangitis. So you have a myriad of differentials, and it's essentially a diagnosis of exclusion. We say, well, maybe the patient has autoimmune disease with anti-smooth muscle antibodies, autoimmune hepatitis, low yield for USMLE, okay, but I just mentioned it here as a distractor. When students may have heard that before, but they're not sure, they tend to choose weird sounding shit. Choice D, elevated serum kappa, wrong answer. This refers to multiple myeloma, okay, so you're going to have plasma cells that secrete kappa or lambda IgG, okay, and it's called an M protein spike. And you're going to have high serum calcium, back pain, classically, lytic lesions, Bence-Jones proteinuria. You're going to get renal amyloidosis, cardiac amyloidosis, and you can get high ESR causing rouleau formation, okay, stacked RBCs. Wrong fucking answer. Choice C, hyaluronopathy, wrong answer. This is sarcoidosis, okay? I mean, this is very buzzy bihyaluronopathy, classically African-American woman, 20s to 40s, who has dry cough over many months, might get erythema nodosum, red shins, and can get fever with flares, okay? And they just love giving you the chest x-ray finding. It's very pass level. They say nodularity around the hilum on a chest x-ray, okay? You just need to know it's sarcoidosis, nothing dramatic. Correct answer is thrombocytopenia. Now, this is medium difficulty because many students aren't aware that this is high yield for lupus, all right? So you get autoantibodies, not just against double-stranded DNA and ribonuclear protein anti-Smith, as I mentioned before, but you can get autoantibodies against your hematologic cell lines. Okay, so you can get low platelets classically. You can also get low RBCs and low white blood cells. If all three cell lines are down, that looks like aplastic anemia, but it's not aplastic anemia. There's nothing wrong with bone marrow production. It's peripheral destruction. That's asked on one of the 2 CK forms, actually. So you need to know autoantibodies against your hematologic cell lines. So also antiphospholipid antibodies, okay? So a false positive VDRL test for lupus, recurrent miscarriages in SLE, okay? But autoantibodies against platelets, very high yield. You'll see thrombocytopenia quite a bit, especially in 2CK level questions for SLE. You know the deal. I'm going to continue to make more content. If you like my stuff, subscribe my channel. And I appreciate your time. That's it.